So we can start this special session tonight. Welcome to everyone. It's a big pleasure for us, REGEDENT, to host this webinar with Professor Anton Friedman and Dr. Thomas Gottwald. This event is special for us because we will discuss today a topic and novel therapy that we are bringing to the market that can help patients with periodontitis and peri-implantitis. This is a journey that REGEDENT has been doing this past 10 years. We've been investing in a significant amount of studies with regards to two products, Perisolv and hyaDENT, respectively, sodium hypochlorite and cross-linked hyaluronic acid. And all this research is now arriving at a culminating point where we've been able to develop a comprehensive, intuitive therapy that we will cover tonight. So, gentlemen, if you're all ready with me, let me first just give a little brief on how we will do this session. So you will be able to ask questions with the app, the Q&A app that you have at the bottom or at the top of your screen. And we will cover these questions at the end of the session in roughly 1 hour. We will divide this evening in several parts. The first one will be to speak about the products and the solutions that have been developed. We will cover the challenges that you're encountering in your practices today with regards to periodontitis and peri-implantitis. And obviously, we will go through clinical cases and scientific data to lead at the end to the conclusion where we will address the question and answers. This session is recorded tonight, and you will receive after this session an email with a link to watch the video again. So that's about it. So on this note, let me introduce our two key note speakers. First one, so Professor Anton Friedman. You are since 2010 full-time professor and chair and head of the Department of Periodontology in the University of Witten-Herdecke in Germany. Since 2011, you're director of the ITI Study Club of Witten, ITI Fellow, and you're an international keynote speaker and specialist in periodontology, DG Paro, and implantology with the DGI. You hold a long experience in the dental surgery topics. You started in '93 already with a thesis about healing pattern around titanium implants using non-resorbable EPTFE membrane. And you completed this research and PhD in 2008 with your thesis about insights into augmenting and maintaining alveolar bone around dental implants in patients with a history of periodontitis. Since 2000, you're active in publishing at the international level, and you hold an H index of 21. Did I miss anything?
No, it's correct.
No?
Fantastic. Thank you.
Thomas Gottwald. So today you're not so much invited as the managing director of Germany, who was the founder of REGEDENT, but you're invited because of your expertise throughout your career in regenerative biomaterials. And you're going to be able to share the technical aspect and technical aspect of what has been developed. You have a career that has gone through the Straumann Institute, where there you were active in R&D in the development of different biomaterials, and you started before that another company, Tutogen, where there you were already in research and development for biomaterials. You an engineer from the University of Würzburg, and that's about all. Cool. On that note, I will give you the stage, and all the best.
Thank you very much for the kind introduction. And let's go on. I will share my presentation. Here we go. Well, and today I would love to welcome all of you. Thanks for joining us. And I present this wonderful and very intriguing topic, how to avoid surgeries treating peri-implantitis and periodontal infections. It's kind of a new approach, and we share the stage together with Thomas because he will support me in several issues today. So to set up the stage, we are talking about severe periodontitis, but also about severe peri-implantitis today, looking at infrabony defects, first of all. According to the recent classification of periodontal and peri-implant diseases and conditions, we treat stages 2, 3, and 4 periodontitis with various grades, B and C, probably here in our patients, which I will share with you among the cases. And of course, we have been treating periodontitis almost since ever, and always we were looking to establish a certain amount of stability in the periodontal tissues. But this the new classifications give us the chance really to summarize, to sum up all the conditions which we consider important for so-called periodontal stability in long term. These are the parameters like probing depth, which should not exceed 3 to 4 millimeters without any signs of bleeding, so without any inflammatory reaction. And we talk in case of periodontitis patients about so-called closed pockets after the completion of the course of periodontal treatment. And overall dentition extended to all present teeth, the BOP frequency should not exceed over 10% of all sides. If these conditions are given, we consider even in the periodontitis patient as a stable case of periodontal health, which can be altered by some gingival inflammation present in several parts of the dentition, in several regions of the mouth. But if we have again a periodontal conditions with some kind of recurrency in probing depth changes and bleeding on probing, so we have to consider that the situation is unstable and we have a recurrent periodontitis. So on the right-hand side on your screen, you see such a positive example after a series of periodontal treatment measures, where we have finally probing depth of 3 millimeters without any signs of inflammation clinically. And of course, the tooth, this last premolar on the maxillary side, has had a history of severe attachment loss, as it is indicated by the recession here in these two images. So this is a positive example. What we are regularly treating are these conditions as well as less severe conditions. And we always aim at tooth maintenance, but also at the improvement of periodontal conditions, at the improvement of the attachment apparatus. And doing so, we have to respect the treatment timeline. We have to define and to determine the cost-related therapy. We have to develop the patient and our relationship to the patient, of course, in terms of controlling the infection, the inflammation, controlling the patient's behavior regarding smoking, diet, and so on, regarding the general health conditions, diabetes, stress, and so on. Finally, motivating, scanning, route planning, applying if required and if it is indicated systemic antibiotics, and of course choosing the strategy according to the type, extension, severity of disease, and at the individual level. The outcomes we are focusing at are expected probing depth reduction, gain in clinical attachment level, and it always goes along with some recession onset just due to a certain shrinkage of the gums of the soft tissues. So in this particular case, all these steps have been followed. The anti-infectious therapy, the step 1 therapy, was performed after the splinting the mobile teeth, which were of course mobile due to the attachment loss extension in this case. And afterwards, after completion of stage 2, we have to reevaluate the situation about 8 weeks later. In this particular case, of course, the decision was taken about the systemic antibiotics. The patient was quite young in age as the treatment has been done, and he received the Van Winkelhoff kind of systemic antibiotics, amoxicillin combined with metronidazole. So still, we have to count on residual pockets, such special situations as vocation involvement, and also deep, very deep pockets, as it has been here shown at this baseline X-ray overview in this particular patient. So the goal is not only to somehow retain the teeth, but also to improve their performance, the maintenance of teeth, and of course the improved attachment level. So here, 2 years after the beginning of the therapy, the X-ray control, I think, very impressively show it is possible to improve the teeth in their conditions. And to improve even the attachment level very effectively. It took about 6 visits for SPT, and this re-evaluation I share here with you shows that we managed really to get the probing depth down to level of 2 to 3 millimeters, maybe one side showing 4 millimeter depth, but in general, we can consider that this case has been stabilized and was successfully treated, as you saw already on the X-rays. But we have also to take into account that we have to affect the patients in their behavior. We have to change their own lifestyle, their own approach regarding smoking and several other aspects in the daily habits and life. And it is difficult. And of course, you all are aware how difficult it may become. And not everyone agrees on our recommendations and follows exactly our suggestions in regard to smoking habits, or to in regards to compliance regarding the SPT visits, the regular SPT visits, the steps of oral hygiene. So, and knowing this, of course, we know that our efforts maybe sometimes fail or are less successful. So in this case, the situation looked finally like this. And of course, the size of interdental brushes has to be adapted dynamically to the situation. Regarding the efficacy of subgingival instrumentation, we have this very nice meta-analysis, which was presented at the last Euro-Perio meeting. And it showed that regardless the choice of instrumentation, either being performed by hand instruments or by ultrasonic instruments, the outcomes will be equally successful in regard to pocket closure after 6 to 8 months during the re-evaluation, the maintenance phase. And in regard to the clinical attachment level gain, also the approach of subgingival areas to be instrumented is more or less equally weighted. Either ultrasonic instrumentation or hand instrumentation plays the game and achieves the results. Usually, nowadays, I think the specialists are eager to combine even both types of instrumentation, and they alter the ultrasonic devices with hand curettes and instrumenting by both principles. Regarding the full mouth disinfection performed at once versus quadrant-wise SRP, we see that there was a tendency to favor the quadrant-wise approach for subgingival instrumentation. You can see it here on this diagram. So you can use both ways, but you have to be aware that you do very thorough cleaning, very thorough and meticulous instrumentation, cleaning up the root surfaces, completely avoiding any residual calculus subgingivally without exception. So in principle, the non-surgical periodontal therapy is effective in terms of establishing pocket closure, as it was confirmed by this another systematic review and meta-analysis from an Italian group. But yet we know from this famous publication from the University of Bern that we do have to count on some residual pockets exceeding 4 millimeters in depth, and these residual pockets may be associated with extremely upraised odds ratios for tooth loss. If we have more than 5 millimeter of residual pocket depth, you see the numbers are growing geometrically. And accounting for this knowledge, please set up your own goals in terms of successful treatment for sustainability reasons and insist on shallower pockets than they were initially present. And we know from the guidelines, from the EFP guidelines to treat periodontitis stages 1 to 3, that this third step is recommended to be a surgical step, to perform surgery in these kind of infrabony defects in terms of gaining additional attachment level, or to do resective surgery to minimize the pocket depth surgically. And again, the success of this treatment is given first if we can combine the gain, additional gain of clinical attachment with the residual pocket depth, which should supposedly does not exceed 3 to 4 millimeters in depth. First, if both conditions are fulfilled, are given, we can talk about successful regenerative treatment according to this analysis performed by Trombelli's group some years ago. Just to now give you an idea what we are treating today in our lecture, is this situation. It is not about the indicated teeth, which have had endoperio problems. They have been treated during the active phase of treatment successfully, but we are looking at another tooth, at this smaller mandibular molar on the left-hand side, and initially it was presented with a 9 millimeter deep pocket on the mesial aspect. It has been treated conventionally by my postgraduate student, and finally, a couple of years later, this tooth for the right, as you can see, the measurements were okay with a 3 millimeter of probing depth. Radiographically, the tooth was looking improved, but later on, during the SPT visits, we had to diagnose again recurrence of the pocket, and you see this, the situation with bleeding on probing with again radiographically observed destruction. And now the question is, should we apply a surgical approach, or do we have some alternative pathways to improve the situation for in long term without surgery? And I would switch now to Thomas. Please, Thomas, now we will talk about the clean and seal strategy. Thomas?
Yes, I'm just sharing my presentation. So I will try to give you a brief background in the, let's say, scientific activities that we have done for this concept that we were happy to launch actually last year after tremendous efforts we did regarding the proof of concept. And at the third part of this today's presentation, Professor Friedman will give you certain clinical and case relevance of all of that. So the clean and seal concept is actually a biofilm concept. We have in the first part an instrumentation that Professor Friedman has pointed out to be the relevant part of treatment of gingival or peri-implant infections. And one of the crucial parts of the biofilm eraser, which is called Perisolv. I will present you later the potential of this device. It helps the subgingival instrumentation. And at the end of the instrumentation, we have kind of a wound sealing, which is done by a cross-acid. I think many of you have heard of that. And this is in an optimal world, which we hope to provide, providing also a periodontal regeneration, or let's say re-establishment of the tissue around the implant. So the first question I try to answer is, what is Perisolv? Maybe the older participants of you still know Perisolv, which was a Swedish invention for caries treatment, and from this company also a device for periodontal application was invented. It's called Perisolv. Meanwhile, we own that brand and this technology. And Perisolv is actually a two-component device, which consists of sodium hypochlorite, I think a substance that everybody of you is well aware of. But to, let's say, in order not to bring you into fear or into a horror movie, the sodium hypochlorite is buffered in this device with amino acids. And this is actually the very important fact about that. Therefore, in the device, there's a connector and an applicator so that you can, before application, mix these devices and have a facilitated application. So, talking about Perisolv, we have 3 to 4 aspects that we regard as being highly important for its use. So it's actually the more efficient biofilm removal. This is certainly due to the presence of sodium hypochlorite in this device. In addition, and this is most likely the most important feature of the device, it's that you have a more efficient removal of granulation tissue and also of subgingival calculus. Which is important because then you have something that really helps you in your non-surgical intervention problems, because you are not working under site, you are sticking somewhere, and especially on the implant, it's very, very difficult to get something instrumented very efficiently. And here, this gel helps this. The thing which is also very important is that Perisolv reacts very quickly, so you don't have any retard function necessary. So you have an acute effect, which is within several seconds. So usually you apply it and allow it to stay for only about 1 minute, and then you can continue. And this is something that you would not expect of a device which contains sodium hypochlorite, but this is due to the presence of the amino acids. The device is gentle to healthy tissue. And I want to show you a movie that shows you the good advantage of this device. And I would invite Professor Friedman to comment this movie because he provided us with it. I will just start it, and Professor Friedman will comment.
Yes, thank you, Thomas. This is an injury by scalding of a shin bone, and it was already necrotizing, as the person who was affected didn't show up for 2 weeks after the injury by a doctor. So she consulted me as being a dental hygienist in our clinic. And so I suggested to apply Perisolv to clean up the site. And now you see already on the video, I'm applying the XHI, and underneath we see some vessels without any cover by connective tissue. So it was a really deep, big infected area. And the epithelialization went on step by step. We applied several times and for many, many days Xia, so the hyaluronic acid on this wound area, just because it was regularly daily whipped off, of course, by trousers at home and at the clinic. So she had to reapply the hyaluronic acid to support the healing, but finally it healed completely without scar tissue development at all. Thank you.
Yeah, thank you for commenting. To give you maybe some more background about that, this concept. So this device is also applied in the medicine for treatment of chronic diabetes wounds, and also for decubitus for patients who lie in bed, who have open sites which don't heal for themselves, and therefore this was also part of the idea to treat this chronic wound with our CLEAN&SEAL concept. So talk about the scientific background of Perisolv, let's say in respect of dental and implant treatment. We have, for all of the devices that we market, we have done a 3-level evidence. So we start in vitro to see what is working on the cellular level. And here you would see that Perisolv doesn't affect the dentine surface, as well as it doesn't affect the implant surface. Further experiments show that these surfaces support the cell growth significantly compared to the control. So we have, let's say, done this proof, which is also very important, taking into consideration, let's say, the guarantee you get from an implant, because this is a method to clean the implant without affecting the original surface. About in vitro and clinical, we know that Perisolv facilitates the removal of biofilm and the granulation tissue. Here you see on this slide a removed granulated tissue after treatment of a peri-implantitis defect. I think this feature Professor Friedman will discuss later when he presents to you the clinical cases. And clinically, mainly certainly on the level of periodontal disease, we have shown that additional application of Perisolv to subgingival instrumentation will result in a higher reduction of probing depth. And what is very, very important, and especially for the aesthetic importance of your patients, that it's not only a reduction of the probing depth, it's an improvement of the clinical attachment. So this is something to say that although there's hypochlorite in it, Perisolv is very gentle to soft tissue. And what is the very important thing is Perisolv improves significantly the bleeding on probing. Also, if you see here in comparison to placebo or also to chlorhexidine, which makes the material very, very interesting and efficient to control subgingival or submucosal infections. One case that presents to you the good ultimate effect of Perisolv would be this inflamed pocket, where you see on the left the deep pocket, which is acute infected pus flow. In the middle, you see the Perisolv treatment in combination to subgingival instrumentation. And on the right, you see the result, the early result after 2 weeks, where you already see the stippling of the soft tissue, a really healthy state, to show you also the gentle application of this cleaning gel. Talking about hyaluronic acid, this is a device that we already have in our stock for many years, but we were not very much active on the market because we got this device when the idea in the market was more aesthetic and not regenerative. And we used the last 5 to 10 years to build up a very strong evidence level in certain disciplines, including the non-surgical treatment of periodontitis and peri-implantitis. So talking about hyaluronic acid, it's certainly a natural physiologic substance. It's one of the main components of the extracellular matrix, mainly certainly in connective tissue or the joint fluid. The interesting thing is that pure hyaluronic acid is the same for all species. So it doesn't matter if it's human, porcine, bovine, from chicken or wherever. The hyaluronic acid molecule from a chemical standpoint is the same, which is very good. And the fascinating aspect, and this is something that is difficult to understand, 1 gram of hyaluronic acid binds up to 6 liters of water. And this makes it interesting for a lot of disciplines and is one of the reasons why hyaluronic acid is one of the main players when we are talking about wound healing. How is manufacturing of modern hyaluronic acid realized today? So it's a 2, respectively a 3-step process. We are starting with the manufacturing of raw natural HA, which is not an animal origin anymore. It's today a highly controlled technical process using bacterial fermentation like Streptococcus. They are triggered to manufacture natural hyaluronic acid. Certainly at this time with certain impurities. So the important next step would be the removal of bacterial proteins so that the material is chemically pure natural hyaluronic acid. And the third step would be optionally a cross-linking, which is mainly supposed for improvement or prolonging of the degradation time in the body, but it also influences the physiological effect that hyaluronic acid has. And this a topic would be to discuss about the different options or the different modalities how hyaluronic acid could be, but this would be too long for this session. So today I would only highlight quickly the difference of natural and cross-linked hyaluronic acid. Natural hyaluronic acid, this is a device that has a very, very strong, high regenerative potential. But if you add it to the body, it's very quickly degraded. So it only has a limited effect on the regenerative properties. Therefore, on the other hand, the cross-linked hyaluronic acid, by cross-linking, you can prolong the presence of the hyaluronic acid in the body. But on the other hand, the more the material is cross-linked, the less it's efficient and the less it's effective for supporting regenerative disciplines. Now coming to the hyaluronic acid that we are providing, where we have established a scientific database. It's a surgical cross-linked hyaluronic acid, which features it's cross-linked, but only to an extent that the physiologic function is still maintained, as well as the strong regenerative effect. But the presence of the hyaluronic acid is for several weeks. And the cross-linked hyaluronic acid also has a name. It's called hyaDENT BG, like a barrier gel, which is a highly concentrated hyaluronic acid composed of a cross-linked and to a small part also to a natural hyaluronic acid. So you have more or less both worlds in it. And it has a slow degradation profile of several weeks, which is, as I can quickly show you later, long enough not only to support wound healing, but also longer processes like periodontal and bone healing. If you look in the literature, then it's actually very surprising that we are the first who are really dealing with dental application, because hyaluronic acid has a long track history when you talk about regenerative or wound healing effects. And this is a quick overview about only a small part of literature that it's available. And I will now highlight you quickly one of the, according to our opinion, key advantages of hyaluronic acid for use for non-surgical therapy. So here one of several examples of a split mouth study or a prospective clinical study talking about wound healing. This is dealing with removal of free gingival grafts and dealing with patient comfort and the speed of wound healing. And when you see the pain score of the patient, then you will find out that additional application of hyaluronic acid in the wound is significantly reducing the pain feeling of the patient. On the other hand, the epithelialization, the re-epithelialization of the wound is done significantly faster. So actually the wound is closed 1 week faster than without hyaluronic acid. In addition, people face less swelling. So all parameters that you would wish for wound healing are improved by just adding hyaluronic acid to an, in this case, oral wound. Here I will show you some features of hyaluronic acid when it's applied surgically in terms of wound stabilization. You see here this exposed root surface. On the right, you will see the situation shortly after hyaluronic acid was applied. It has a consistence and a visual like hair gel. So you would not really see the hyaluronic acid. But look what happens some seconds after application. The blood does not wash away the hyaluronic acid. The opposite happens. Hyaluronic acid attracts the blood and stabilizes the blood clot on top of the root surface. And this is certainly very, very important if we are talking about periodontal regeneration. So hyaluronic acid supports the wound healing in all phases. It reduces also the scar formation. You have also seen in the surgical video that we have presented you. It has a simple application. And it provides wound stabilization. If we would talk about GBR, you could also provide the sticky bone, but this is not the topic of today. And HA supports the fast tissue regeneration and tissue repair. And I would like to highlight you to the evidence we have done to non-surgical and surgical periodontal therapy. So talking about that, in vitro, hyaluronic acid increases the surface roughness of dentine. So to summarize, HA brings its own root conditioner with it. You don't need to perform a root conditioning. HA roughens the root surface by itself. HA stimulates the periodontal cell growth on these surfaces. We have shown in vivo that hyaluronic acid leads to a true periodontal regeneration. So like with amylogenins or with the GTR procedure, you have now a third player where you have evidence for real periodontal regeneration. And in clinical, we have high-level clinical studies, even a review with a meta-analysis showing that in non-surgical application, all parameters are improved. So probing depth, specifically the clinical attachment level, as sign of the good effect of hyaluronic acid to soft tissue, and also it reduces bleeding on probing. The same is a fact if you would apply it surgically, not topic of today, but also here you would have a beneficial effect, which is proven in a meta-analysis. And the highlighted workflow, if you look at, for example, here a surgical workflow, you have the flap preparation, you have the instrumentation, root conditioning, drying, application, and the wound closure. If you look at hyaluronic acid, you don't need to perform root conditioning and you don't need to perform drying, because these are two advantages that hyaluronic acid brings with it. So actually you can do whatever you do today, but in a shorter clinical pathway. Last but not least, if we are talking about peri-implantitis treatment, you always have to look at the effect on bone regeneration. And this is a short summary on the clinical evidence we got for the beneficial effect of hyaluronic acid in bone regeneration. So in vitro, the cross-linked hyaluronic acid stimulates the cell growth of bone cells. In vivo, we know hyaluronic acid leads to a significantly faster bone regeneration by means of more mineralized tissue and less soft tissue in the wounds after a short time. Clinically, in clinical studies, human clinical studies, you will see that you get significantly more bone, less residual graft materials, and less soft tissue. We did not believe it in the first time, but we have several studies which give us this result. And by that, I would like to end the tough scientific part and would like to hand over to Professor Friedman, who will now tell you the potential benefit you can get from this concept in the non-surgical treatment of periodontitis and peri-implantitis. So looking forward to your clinical fireworks, Anton.
Thank you, Thomas. Well, dear all, let's look at the clinical evidence and the results applying the combination of clean and seal approach, the Perisolv and IXIA in periodontal and peri-implant non-surgical approach. Actually, I saw right now the answers you gave to Alexandra on the poll questions, and I want to pick up on it. Let's talk a little bit about adjunctive protocols in general, adjunctive protocols to our subgingival instrumentation, which are available. And of course, you all know there are plenty of options, starting with the lasers, going over to PDT or photodynamic therapy, or to using several antiseptics like chlorhexidine, for example, and so forth and so on. Actually, I've tried to convince you that the approach we are proposing today has really a very impressive prolonged effects. It is not really definitely working on the microbiological aspect alone, or it does not do any kind of mechanical sealing of the pockets, but it does work just obviously according to our meanwhile published and collected data and to our evidence from different research groups who are working in this direction, that we do have a really biological response just according to the way of action of these two substances, of these two applications. And looking at the protocols, we can ask the question, should we approach the subgingival instrumentation at step 2, adding the clean and seal protocol to this anti-infectious therapy? Should we consider the repeated subgingival instrumentation at SPT visits at sites which usually would undergo any surgical treatment? And should we use it also in conjunction with the recurrent pockets at SPT afterwards, or with the residual pockets? Let's look first of all into the very new data which are under review currently. The paper is submitted and the first revision is already passed. So I'm very much looking forward to seeing these data published soon. And this is a clinical study, an RCT study performed by Egle Ramanoiskaite together with her colleagues and under supervision of Anton Skulian from University of Bern. And what they have done was just clinically approaching the stage 2 and 3 patients, randomly assigning part of the patients to the conventional control group, where just the subgingival instrumentation has been performed, and the test group received additionally the clean and seal protocol. And you see in the diagrams I share here that within 6 months we have mean changes in probing depth, as well as in deep, in moderate pockets and in deep pockets. And in the test group, the improvements are significantly higher, significantly greater. And very nicely, you can also see that the third bar here, shown in red on the diagrams, displays the dynamic in the change or in the further ongoing improvement between month 3 evaluation of the data and month 6, which implies that the effects are prolonged. It is not the immediate effect, just placing the material into the pockets after instrumentation, but we have definitely a prolonged efficacy in terms of gaining attachment, additional attachment during further 6 months after the treatment. So these are the diagrams regarding the clinical attachment level change and gain, as in shallow, as in deep pockets and sites. And again, also for this parameter, the same observation is true. The gain is considered ongoing from month 3 to month 6. Regarding the bleeding on probing tendency, we have significant reduction in bleeding tendency from baseline to month 3, and also to visit for 6 months observation and evaluation. So also here we see prolonged changings, and talking about the change in the number of sites, measuring 1 to 3 or 4 to 6 millimeters, we have a really very impressive improvement in the numbers, and an impressive significant change from moderate to very shallow pockets after 6 months, and also a dramatic reduction of deep pockets from total at baseline of 1800 down to 230 in the test group after 6 months. So congratulations to the group, and I'm looking very much forward to seeing these data published very soon. So this was the initial treatment, the step 2 treatment, anti-infectious treatment combined with the CLEAN&SEAL protocol. We did a study on our SBT patients, so patients from the maintenance phase, who has been visiting SBT visits for several times before we subjected this protocol to the pockets which were still bleeding, were still active or even recurrent, as I indicated at the introduction part of our talk. So the protocol is very, very simple. You don't have to change your attitude. You don't change the way you treat. You can use either ultrasonic or hand instruments or both together in combination. Just one point is very important to address and to keep in your mind, as 60% of today's participants answered to the poll question. You are using the chlorhexidine for additional decontamination of the pockets. Please, using this protocol CLEAN&SEAL, please stay away, avoid any contact of tissues subgingivally to chlorhexidine. It does not help at all. It is rather does hinder the positive reaction, the reaction of Perisolv in the pocket, because if it comes to a contact between hypochlorite and the chlorhexidine, the reaction neutralizes the substances, active substances. It doesn't help at all. So we here apply for about 40-45 seconds the hypochlorite into the pocket. Then we instrument by hand instruments, usually the deep sites, and we several times may repeat this action once we consider the surface cleaned up and smooth. We remove actually by the use of Perisolv, we also easily remove some granulation tissue without even focusing on it. It is very helpful in this regard. And then after irrigating the pocket with the saline or with hydrogen peroxide solution, we apply the hyaluronic acid, and we just let the patients go home without changing their attitude regarding their home care. So they go home, they can brush the teeth, they can use interdental brushes immediately after the procedure. We don't care about, and they don't have to rinse or irrigate additionally. In this our approach, this is our patient cohort we evaluated in this retrospective analysis. The mean probing depth was exceeding 7 millimeters, and the clinical attachment level loss was even exceeding these residual probing depths, because of course some recession took place before, so it was about 8 millimeters. So the results were very positive also with this group, and with our approach. We improved the probing depth, or we reduced the probing depth by 2 millimeters, winning or gaining additional clinical attachment also by 2 millimeters, which means at the end of the day that we didn't experience any additional recession development. We just saw the improvement of the pocket conditions, and also ongoing improvement of bleeding tendency, reducing almost from 100% in the beginning, the tendency of bleeding down to just 40% after 6 months. If we subdivide the population in different defects in the furcation involved teeth, the effects were maybe a little bit less expressed, but in general it was very similar. Finally, the pocket seal was achieved in terms of negative bleeding on probing and residual probing less than 4 millimeters in depth at the 6 months in 25% of the almost 100 treated non-furcation involved sites. And later on, waiting for another 6 months, and we documented these treated sites radiographically. And now you can see from these images that the sites healed not only clinically, but they improved, in fact, radiographically after 12 months, as it is shown in the next slides here on the bottom of the screen, also in this young patient in the molar area in this tooth. Also, the other cases done by my colleagues, also former members of the department, postgraduate students, as it is shown in this case, we regularly see 12 months after the procedure this impressive improvement of the radiographic display and of newly mineralized tissues. So the idea was born as we saw this protocol, CLEAN&SEAL protocol for treating mucositis actually, and we adapted it to our periodontal situation in the pockets. And some other further cases are very encouraging, I think, and very impressive. This is a condition of a patient who joined the treatment at the department several years ago. This is the baseline information, and the residual pockets after the course of anti-infectious therapy, after several root canal treatments were still there. And finally, the CLEAN&SEAL protocol was applied at SPT visits, and you see the radiographic control from left to right X-ray, periapical X-ray, which shows the improvement 1 year again after application of the CLEAN&SEAL protocol in the mandible, in the maxilla, on the right or left hand side. And currently, an X-ray I took from this patient after I took over the responsibility for this patient. I did the panoramic X-ray at the beginning of this year, and checking the probing depth, I can tell you at this moment, as this X-ray was taken, there was no pocket exceeding 3 millimeter in depth. So we referred the patient further to our colleagues to start the orthodontic treatment. I removed the splinting on the left-hand side of the dentition. The teeth were absolutely mechanically stable. They were not, absolutely not hypermobile, and now the patient undergoes this orthodontic treatment. The other case I showed already here before. This is an adolescent patient with a deep bite with traumatic occlusion, which costs, of course, a lot of attachment in this in the front area and anterior teeth, and also the mandible molars on the right side of the mandible. And also here we used the CLEAN&SEAL protocol in the maintenance phase, and 12 months later, after approaching these residual pockets at the center, incisors in the maxilla or here in the molar area, it improved radiographically very, very well. So generally, recommendations to use the CLEAN&SEAL protocol include the strong recommendation not to irrigate subgingivally by accident at all. We don't need any dressings, sutures, or sealers for the pocket after we apply the hyaluronic acid. And we don't restrict the patient in the mechanical home care. The oral hygiene should be performed as usual. We, in our clinic, recommend also a double application of hyaluronic acid. So we repeat just the filling of the pockets with hyaluronic acid within first week after instrumentation. Some more examples show continuously similar results, also from the private practice here. Even with these awful kind of restorations, still the principle works, and you see the improvements as clinically as on the X-rays 1 year after. So from our study, we concluded that the CLEAN&SEAL protocol is sufficient as in regards to pocket closure, in terms of shallowing the pockets down to 4 or less millimeters in depth without bleeding, but also in regards to the necessity to perform surgery. We did avoid this recommendation by 100% of all treated sites, as the residual probings were not exceeding 5 millimeters any longer after 6 months. But of course, more studies are required. Actually, you may ask the question, how is it about focations? Here we don't have such great base of data, but the results are still encouraging and very promising. As you can see here in this patient, we applied this protocol after several years of maintenance care, and this tooth was very mobile, and it was really painful to chew on it. And I was almost taking it out, but I suggested this new protocol to the patient, and we did the treatment. And on the right-hand side, on the X-ray, you see the improvement as looking at the marginal bone conditions, but also looking into the focation. It was initially here at the beginning a grade 3 focation. Of course, it remains as grade 3, but it is now cleansable. The granulation tissues are removed completely, so it doesn't hurt if the patient approaches the tunnel here by the interdental brush, as it was impossible to access before treatment. Also in this case, the patient came for the second opinion because the colleagues were about extracting both molars, and we agreed upon treating with a clean and seal protocol here, both sides of the maxilla. And you see the changings are really impressive, as radiographically as also measuring the changes in probing depth. And we see the reduction by almost 6 millimeters in depth on the very distal aspect of the tooth, and the furcation involvement was improved down from grade 2 to grade 1. It is not probable any longer between the roots. Now let's talk briefly about the peri-implant application in the infrabony peri-implant defects. You know, they respond not really well to the mechanical treatment. Even using the mechanical treatment together with, in combination with period chip or lasers, the improvements of clinical probing are not really impressive 1 year later. And here also, I was thinking it should, once it does work in the perio, it should be helpful also in the peri-implant disease situation. And we have, of course, to consider a combination of mechanical treatment and mechanical approach and chemical disinfection of the surfaces. And the best way, according to in vitro data, for example, to clean up the implant surface is, for example, the air powder abrasion. So we combine it with the clean and seal concept, non-surgically, and we use also clean and seal as pre-treatment step prior to the surgical approach, applying hypochlorite and also hyaluronic acid for infection control, as you can see it in this case. Here you see in the center, on the center image, a lot of separation during probing here around this implant. And of course, we did this surgical approach here after the situation of the soft tissue and of the inflammation was very well improved by using non-surgical clean and seal application. This is the defect extension, and in this case, I focused on the surgical treatment, but we also have enough experience, positive experience with non-surgical application of clean and seal protocol, as it is shown in this. In this case, it was a case done after sinus grafting and staged implant installation. The implants were integrated, they were loaded conventionally by two splinted crowns, but just few years later, the implants showed signs of inflammation associated with bleeding, with very increased deep probing depths along the implant. And after we applied for several times the combination of hypochlorite and hyaluronic acid, the situation finally resolved completely, as you can tell from the X-rays now, a couple of years later. And also clinically, the situation is absolutely stable without any signs of gingival inflammation or mucosal inflammation or bleeding on probing. My colleague, Dr. Young, shared this case with us for today's presentation. Initial probing was 10.88/9.88 millimeters. This is the X-ray of this post here. And even less than 12 months later, it was about now 8 months after treatment by CLEAN&SEAL protocol. You see probing depth does not exceed 5 millimeters, and this is the X-ray which was taken at this moment, at this reevaluation. And after these values were available, the scores were recorded, my colleague did even the free gingival graft in this area to improve the soft tissue situation. A colleague from Switzerland has done a series of cases, very impressive cases, non-surgically. The patients are referred to him for peri-implant therapy. Here we look at the tooth to one, or implant in position to one, in terms of postponing explantation of the implant, because you see it was really in the center of your screen. You see a very huge peri-implant defect, very deep peri-implant defect, which was even worsening from year to year. The clinical image is shown here. The probing is very, very deep, with separation, with pus. You see there in the sulcus here, pus is coming out. And the protocol, the colleague suggests, Dr. Lichtel always uses, is under local anesthesia. In this case, he did not remove the framework. He uses Perisolv for 30 seconds, but he repeats this treatment for several times, 6 to 7 times, irrigating with saline solution and doing the curettage, the removal of granulation tissue, and also working on the implant surface. Finally, irrigating with hydrogen peroxide and applying then hyaDENT BG, the hyaluronic acid, and prescribing also Citromax, which is azithromycin 500 milligrams for 3 days. And afterwards, these patients in his hands have to rinse the mouth 2-3 times a day with chlorhexidine after the procedure. So, So this is how it looks like 2 weeks after the treatment, 3 weeks without signs of inflammation. And even within a relatively short period, here we have another X-ray taken about 4 months later. We see already very, very nice improvement in the bone conditions in the next surroundings of this aching implant. 6 months later, the clinics is very impressively improved, and here we have 5 millimeter probing depth, no separation, no signs of bleeding. It's a little bit recession here, which is fine, I think. And another control X-ray some more months later shows that the situation is additionally improved. In this case, we had an immediate implant loading with an implant which was placed in the stage approach, and within very short period of time, we saw this situation around the implant neck with bone loss. In this case, I just did a free gingival graft to improve the soft tissue conditions around the implant, but I combined it with non-surgical application of CLEAN&SEAL protocol, and you see 6 months later, we have this very impressive improvement of peri-implant bone conditions. And afterwards, we were able to exchange the temporary crown by final restoration, and the implant is absolutely all right without any problems until today. So looking further into the options to treat the peri-implant defects, of course, we have to consider the surgical approach, and we have a lot of data and meanwhile a lot of clinical evidence in terms of applying the protocol to periodontal treatment in regards to treating peri-implantitis non-surgically. We have a very nice series of cases, but we are still working on our database to have a solid evidence base for you. The results are very promising. In terms of surgical approach, we do have some more data. We just submitted our case series for publication. The paper is under revision now. So our regenerative protocol picks up on this idea of clean and seal treatment without doing any grinding of implants, without any implantoplasty. We do the decontamination of these exposed implants and contaminated implants by applying hypochlorite several times, combining it with mechanical treatment by airflow, and then we apply hyaluronic acid, as you can tell here from these slides here, pre-surgically, just to improve the conditions. And finally, we open the flap, remove the remnants of the previous failed augmentation procedure. The exposed implant surface is decontaminated by Perisolv. Then we apply the hyaluronic acid in combination with the collagen matrix, close the flap, and finally it looks like this after 4 and 9 months, and the situation is definitely improved. We calculated these numbers from 12 patients with a mean monitoring period exceeding 30 months, and the latest cases were under monitoring for 60 months. The youngest were for at least 12 months monitored, because we looked not only at the clinical data, but we also looked at the radiographs 1 year after procedure. So these are the numbers we calculated. We have really very significant and very impressive improvement of the radiographic data, as in terms of the newly mineralized area, peri-implant area, but also in the vertical extension of newly formed mineralized tissues, mesial and distal, at the implant involved. Here are some diagrams which are also part of the paper we submitted. And I would like to conclude that our clean and seal protocol sufficiently enhances the outcomes of instrumentation in previously persistent or recurrent sites, as in periodontology, as in peri-implant situations. And we have really impressively reduced the need in periodontal surgery, as treating initial patients, performing the initial phase of non-surgical treatment, anti-infectious treatment, as also during the SPT control steps. But of course, we still are looking forward to have a higher number of cases and RCT studies to confirm all these positive experiences and observations. Thank you very much for joining us, and the discussion is now open.
Thank you, Anton, for this fascinating presentation. Thank you, Thomas. I propose that both of you come back online. Exactly. We have received quite a few questions, and seeing the time going by, I propose to go straight to these questions and to answer them possibly in English. would you mind starting going through it? I've seen that Dr. Zimmermann, Rainer Zimmermann, asked few questions about our topic here.
Yes, it was about the benefit of clean and seal compared on one hand to, let's say, established methods like amylogenins, and especially about the let's say the additional benefit. I answered it in the chat and would just reflect what I answered him, and eventually, Anton, if you want to add something, you can do. So I told him, okay, you can, let's say, compare it to amylogenins in terms of the hyaluronic acid. So the hyaluronic acid is the part of the concept which would be the alternative to amylogenins, with the difference that actually the clinical benefit is similar, but with a facilitated application protocol. I think I showed that you don't need to condition the root and you don't need to dry the surface, so your procedure is easier. But the clean and seal concept goes beyond that, because the Perisolv component also adds an additional efficacy when we are talking about the pocket cleaning. So providing optimal requirements for, let's say, the regenerative component to heal the pocket. Anton, would you like to add something, or does this reflect in basically what is it?
Well, I can also comment a bit from the clinical perspective. This is absolutely true what you just told us, of course, Thomas. Additionally, if you look at the data, the numbers I just shared today, of course, the talk was going on, and you have just few seconds to recognize the numbers. I can just recapitulate that it is very, very astonishing, actually, that regardless at which step of the treatment we come to the application of this protocol, of the clean and seal protocol, the group of Ms. Ramirez-Kaite did it at the initial treatment, we did it later on, but the results are very alike in both cohorts. The group which received this clean and seal application ended up with an improvement of additional 2 millimeters of clinical attachment gain. Actually, there is one RCT study published by a group of Holger Jentsch in regards to application of non-surgical application of enamel matrix derivatives in the pockets, in periodontal pockets, and their numbers they presented are much less, actually, sufficiently smaller in terms of gain in clinical attachment level than these numbers from these two groups and two different approaches, clinical approaches. So this is, I think, a hint towards that maybe not only the way to use the material is much more easier, but also the confidence that the outcomes are really repeatable and probably predictable is given, I think. Okay.
Thank you. There was a question from Dr. Carolo about the second application of the cross-linked hyaluronic acid, whether it requires before that SRP.
Before SRP, no.
No, so it's the second, when there is the control after 1 week, whether there is any need for SRP before that.
Oh, no, we don't touch the pocket anymore. Once we stopped and finalized the instrumentation at the first visit, we applied for the first time the hyaluronic acid, and at the second visit, or at the next visit, we just take a blunt needle and apply additional portion of hyaluronic acid subgingivally. This is it. So we don't clean up anything. Of course, if the patient do not clean and we see some plaque, some biofilm super gingivally, we will take care of it, of course. But usually our patients are instructed well enough and they are compliant, and so far that they don't show up with any remnant plaque in these areas. But subgingivally, we don't touch the tissues. Okay.
Yeah. Then there are questions on social media, but I see one also popping now with regards to chlorhexidine. Questions about what are the different clinical parameters of chlorhexidine versus the Perisolv. And here another question going a bit in the same direction about the application of chlorhexidine in the surgical side or not in the surgical side, in the mouth rinse. So maybe something to clarify on that topic.
Yes, exactly. Yeah, this is very important actually to somehow subdivide the application of chlorhexidine. We are not talking about mouth rinsing. We are talking, at least in Germany, we know that many colleagues are eager to use chlorhexidine for subgingival irrigation, or even working with an airflow device with air powder systems. They use also for irrigation chlorhexidine. And actually there are a lot of data which show us the chlorhexidine by itself, by the idea of using it, is actually useless subgingivally. I mean, I don't talk about period chip. It is a different story. But using irrigation, using a solution to irrigate the pockets, it is absolutely useless. You can irrigate with any other fluid. You can take saline solution. You can take hydrogen peroxide. Whatever you take, it doesn't matter actually in terms of additional antimicrobial effect. It does not help. The help of Perisolv, in fact, is it stays there for several seconds as long as you let it be there. And during this time, and it was pointed out by Thomas Gottwald, that it works immediately. It has an immediate effect on the biofilm, on the bacteria. And in vitro studies, we saw and we know that it is maybe even more effective than chlorhexidine in regards to certain bacterial species. So we see that we all know chlorhexidine kills everything across all species without any selective effects, while Perisolv obviously really reacts rather with gram-negative bacteria and not that much with gram-positive bacteria. So this is also just a hint. It is an in vitro observation result, but it gives an idea that there are probably very severe differences between both substances. Okay.
Yes, good. There was one question, social media, about the number of cycles of Perisolv and whether this is all applied in one session.
Yeah, they are applied in one session, and there are several cycles possible and even recommendable. It depends, of course, if we do it non-surgically, then I would rather raise up the number of cycles just to make sure that we really get the effect all around and the defect to all granulation tissues and all surfaces involved. While if we have an open approach during the surgical stage, probably you don't have to repeat it in several times. You can do it twice or 3 times, it should be okay. But in non-surgical, in a closed approach, yeah, I think it is really very, very reasonable to do it several times. And actually it does not, definitely there was a chat question, actually I answered it, I think, directly to the person who raised the question. So, excuse me. The question was, does maybe Perisolv interact somehow and affect the cementum layer? So it does for sure not affect cementum, as it does not affect any healthy collagen portions, fibers, which are intact. It does affect really damaged collagen which has already signs of degradation, where the fibers are not longer intact and were affected already by the inflammatory reaction. And this is the difference. Okay.
Thank you. There are 2 questions also about Perisolv in surgical applications. The first one is, what is your opinion about the use of Perisolv in a surgical approach in open flap surgery to clean an infection area?
Yeah.
And then the second is, whether it can be used in open debridement.
Yes, you can, and I have been doing it for several years already, at least at the implant surfaces in the peri-implant defects. It is also very effective there, and there from I can really confirm that it does definitely have an effect on granulation tissues. I'm trying to figure out now, really in a series of ex vivo experiments, what is the effect and what is the role of the Perisolv on the granulation tissues. It is still an open question, but it does have an effect, and it somehow dissolves the granulations from the bone. It is not sticking onto the bone that much as it usually does after you reflect the flap. First. Second, well, I didn't use it that much in the periodontal surgery because I was thinking once I open up the flap, I should be able to clean up the periodontal side by mechanical means. But today I would rather use it also there after we had very positive results and experiences in treating peri-implant defects with it.
There are questions that were already partly answered directly to the participants that go more about the combination of hyaluronic acid with the bone substitute being xenograft or synthetic. Do you have any experience in that field?
Oh, yeah. I think Thomas mentioned it already briefly in his part of the presentation. We didn't focus on it today because, of course, working non-surgically, there is no place for bone substitutes in any kind and any way. But generally, yes, it is really very, very well in combination with either xenografts or synthetic bone grafts, bone substitutes. I'm using regularly both types. So I love the combination of Ixia and, for example, Osorpia, which is synthetic bone substitute, but also it works very well with even with bovine material, the bio-os material, and also with the porcine kind of xenografts as well.
Okay. We've been around, I think, the key questions.
Maybe one again, the question was for Perisolv application before, during, after instrumentation. I think it's all right.
Yeah, you can consider really all 3 steps actually to use it. First at the beginning, then in the middle, and also at the end. before you do the final step with hyaluronic acid. Yeah, exactly.
Yeah, and there was one open question about CHX, how, when, but I think you explained it already, that CHX not in the pocket, but a mouth rinse with CHX afterwards is okay, right?
Yes, this is okay. As we know from the literature, from clinical experiments from the past, once you use it as a mouth rinse, it does not interact with the pocket. It does not get into the pocket deeper than 1-2 millimeters in the sulcus. It does not penetrate into the pocket. So it doesn't matter if you rinse the mouth with it, but please don't use the syringe and don't irrigate the pockets with it. Thank you.
Very well. But I think that we're coming to the end of this session. I see, Anton, that it's night on your side.
Yeah, my light is getting less.
I just would like to thank you both for your time and for sharing your insights. I would like to highlight that in approximately 1 year, we will hold this first symposium about hyaluronic acid in dental surgery. There will be obviously some presentations, some hands-on session about surgical use of this product, but also the topic that you both addressed tonight will be heavily covered there with all the key experts that we can find internationally. Well, on that note, I'll leave you both the last word, and I wish you all a good evening.
Well, thank you very much for attending, for joining us, and for staying with us till the end. Thank you for the interesting questions and the discussion, vivid discussion, I think. I wish you all a great success using this approach. I really can encourage everyone to go on and tomorrow try to get rid of it and apply it, because it doesn't change a lot of your attitude, and it is really helpful in daily practice and life. And it does a very well job to your patients additionally. Thank you.
Yeah, from my side, I think thank you very much as well. It was a pleasure to be part of it. I hope we gave you some interesting aspects that might help you if you do some perio or peri-implant treatment tomorrow. I think it was not too bad, as most participants stayed till the end. And if you have any questions, also the German ones, feel free to contact us. If you want to know more, get studies or whatever, we are very transparent. You can contact us to any time. And now I leave you, wish you a wonderful evening, and I will have a nice cold drink now, and maybe next time soon. Thank you very much.
Same I do. Have a nice
Bye-bye.
evening, everyone.
Have a good
Bye-bye.
evening. Bye.
Thank you.
Bye-bye.
Bye-bye.